What is Meibomian gland dysfunction?
It's a chronic diffuse abnormality of the Meibomian glands, commonly characterized by terminal duct obstruction and or quantitative changes in the glandular secretion. And this definition was brought to us by the International Workshop on MGD.
MGD. You know, and Mark, my feeling has been on Meibomian gland, when we used to silo and we'd say Meibomian gland dysfunction and aqueous insufficiency and mixed, but it really is, I think it's a spectrum that patients are on, and they're going to develop it regardless of how they start.
100%.
That it's going to happen, it's going to emerge, and it may start out as MGD and non-inflammatory. It's going to go inflammatory, and if you take a look at the consummate aqueous deficient patient, it's Sjogren's patient, right?
Doug, I wholeheartedly agree, and I also 100% agree that we don't blink enough.
Yeah.
And if you're not blinking, you're not squeezing out the meibomian glands, you're not secreting the meibum, you're ending up with caca on your lids. If I saw a patient that looked like this, do I say, how you doing? And they go, I'm doing great, and say, okay, thanks for coming? Or do I say, look at the biofilm, look at the blepharitis, look at the meibomian gland dysfunction, we need to do something different. And you know, you look here at the, you know, the difference between low delivery meibomian gland and high delivery. You see the scaling going on here, and essentially what ends up happening is alteration of the tear film, eye irritation, you know, inflammation, as well as ocular surface disease. All of it. To me, it's like what you just said. It's a continuum.
Yeah, and some people may develop aqueous deficiency sooner. And I mean, you know, take that Sjogren's patient. Initially, they're meibomian glands, but they're not going to be.
Right.
I mean, an advanced Sjogren patient, I've never seen an advanced Sjogren patient with good meibomian glands.
Nope. This is a good graph right here.
Yeah, it is.
Yeah, we see it go down there. We see the obstructive. We can have cicatricial or non-cicatricial. You can have hypersecretory meibomian seborrhea versus the hyposecretion. But again, when you have an abnormal meibum, then you end up having that evaporative effect, causes desiccation, inflammation, irritation. To me, I feel like the meibomian glands are the gateway into discussions, treatments, management of all your patients, that obstruction and that inflammation.
I completely agree. I completely agree. And I think that what we need to do is we need to start treating it earlier, not wait until it's, you know, so if we could start to become proactive instead of just strictly reactive, because right now we're 100% reactive.
Yeah. We collectively as a profession have to walk into a lane and say, I'm glad you came in today. Now I'm going to tell you all the things you need to do moving forward, as opposed to letting patients tell us what they're there for that day. You know, I mean, look at that. You're nasty. You got the saponification going on there, the inspissation. You've got the you know, vomiting in your mouth, looking at that a little bit, you know.
You know, when you look at that saponification, that is just that changing that's taking place of going from a liquid to a solid. It's going through that soap type of phase. And you have somebody, you express some of that more and have the patient blink and say, what does that feel like? They'll say it stings.
Doug, it's soap. I'm glad you just said that, okay? This is soap on your patient's eyes. And for anybody out there who thinks that they can manage this by using soap, like baby shampoo, you need to close the computer right now. You know, no credits for you. Go, okay? Go. Yeah. All right, I was just kidding. You can get the credits.
You can stay.
But again, look at all the problems Paul has.
I know, when we see this, and then, and it's so simple. If you just press on the lids, then you see that picture up in the upper left, the baby oil-like substance, you know you're good. 86% of our patients with dry eye disease have MGD, and we look at that, and if they don't, they will have. I mean, that's...
I totally agree with you. But the other thing, too, about it is you can see it. Where is it? You know, we can look at a low tier meniscus, which is a great opportunity to like look at a Sjogren's patients,
Talk
right?
about aqueous, yeah.
Right. You talk about the aqueous, but even still, those patients have meibomian gland dysfunction because you push on that gland, you see nothing, they've got MGD. You see caca, baby spit up, they got it. It comes out like toothpaste. You go, ooh, ah, right? I mean, you know, it's just not normal, right? I mean, this is staggering when you look at statistics.
95%
like
of patients undergoing cataract surgery had meibomian gland atrophy greater than grade 1.
And the sad part of that is that we're doing cataract surgery younger and younger. And so now we have patients that are going in, but do you know what the number one, well, you know, Doug, the number one reason why patients don't do as well after cataract surgery? It's the ocular surface. But the point being is that if you started managing this before, those patients are going to have a greater opportunity after cataract surgery to have great results.
Here's some of the meibography.
But yeah, look at all the access to be able to assess the function or as well as the anatomy of the gland.
And Mark, I will tell you this. I thought before I had a meibographer that I was pretty darn good at my explanation of what meibomian gland dysfunction was to the patient. And I realized after I could show them a picture that they had no idea what I was talking about.
Yeah.
And I thought, I'm such a good communicator that I know these patients understand that. No, they didn't.
Yeah, I think the one thing that we've learned, especially with MGD, is a picture is worth 1,000, if not, 1,000,000,000,000 words. I mean, just being able to show somebody, especially here, like real-time visualization of that lipid layer, or access, images in 10 seconds of that dynamic illumination, enhanced view of the meibomian gland. It really does make a difference.
Yep. And we have, some of the meibographers will just kind of scroll through them real quickly. These are available, some attached just to slit lamps, that you can capture these images, very compact. They don't take up much footprint either.
You can get
in
a
the
slit
office.
lamp that has an infrared to be able to do meibomian gland.
Yeah, and I actually have that with a photo system that all you do is flip that over and all you do is push on the lid, avert it a little bit, and you get meibography right there. And some of the thermal expressors also will capture meibography at this point.
I think that's
and
right
I think
there.
We'll show one of those pictures. Yeah, that down here in the lower right, this meibography, this portable will actually do meibography, capture the image, and be able to show it to the patient.
Let me ask you a question then, Douglas. You capture the image, you talk to the patient, much like what we did with when we were measuring high-order aberrations during refractive surgery. When we first had the ability to measure high-order aberrations, we'd say, oh, look at your coma. It's like, super crazy high. And then after surgery, you'd want to come in and say, look your coma's higher. Never mind. Do you look at your meibography as a guide to treatment, as a assessment as to how well you're doing, or is it more kind of a looking at where are we now and hoping it doesn't progress?
I use it as a bridge to treatment to be able to explain to the patient what obstruction looks like from the standpoint, and there's some new data, and we'll explore this more in some other programs, where they're looking at removing those obstructions through chemically, and they've actually shown where some glands that appeared to be atrophied are now just that it might be that they don't image when they're obstructed with those lipases, those esterified lipases, that they don't image, and then once they're cleared, that they'll actually fill up with meibum image. So we're hoping that it's not completely atrophied. Then it will absolutely be, what are the results of my treatment, not just, we hope it doesn't get worse.
Yeah.
Now I will, if somebody doesn't want treatment, I will image again in a couple of years and show them, we're slipping, we're going down,
It's a weighted handle. You can just grab the lid and flip it over. You can use the bottom one to pull down. There's some other devices out there too for fair and balance. What this does is it allows anybody in your staff to be able to invert.
Particularly if you want to capture upper meibography and your staff has a problem and you don't have the time to go do it, then it's really one hand, you can flip it over and it's pretty easy.
100%.
And then the meibography and the grading scale on this, and really this can be as individual as the practitioner that you want to have, but if you have the image, you know what baseline is, and you can measure that. But when I start to see this, I think it's so valuable to show patient what normal is and where theirs is. And I had a resident come up to me one time and say, this patient, it's not MGD, it sounds like it, but it's not MGD. And I said, why? And she showed me the image. And she goes, see, all the meibomian glands are fine. I go, well, that's structure. How about the function? What does the function look like? And as it turned out, she said, well, I didn't do that because all the meibomian glands. And I said, well, just humor me. Let's go press on it. Thick, turbid, disgusting type. But the images had started to maybe dilate a little segment. That was on their way to obstruction. And that was what was causing their symptoms. So I think these help. And then looking for the tortuosity that we have in the meibomian glands, they'll start to twist, they'll start to segment a little bit.
Truncate and break off and all that good stuff. Segment. Oh, we have a little video here.
Yeah, showing those meibomian glands. And
But so you have this in your office.
Yes.
And you project it on that, like what, 60-inch monitor or whatever
Yes,
that thing is?
I do.
Crazy?
Yeah. And the technician will actually go through and say, this is a normal image and this is what yours look like. So that when that patient comes in to see me,
They already see this.
they've already seen that and they want to know what they can do.
Yeah.
But that, I mean, very simple. You don't need to put it up on one of these images. You can have something where you can just put it into any kind of a picture, put it on a laptop, put it on a tablet to be able to show.
Nice. Ooh, more digital trends. What do we got from those optometric trends?
Well, what we're looking at is when do you use a Meibomian gland evaluation in the diagnosis of ocular surface disease?
So about 53% said they do it at the initial point of care. How do you do it, Doug?
When that patient comes in, if they are at a 6 or above, they get osmolarity, inflammation, and meibography.
So you do it on a case-by-case, differentiated between the speed test.
Right.
Yeah. I mean, I think what you need to do, and Doug, you make and always continue to make a good point, is that for a lot of you out there who think, oh, I don't see a lot of MGD or I don't have a problem, is you recommend like doing a survey or a sample, right?
Yeah, just taking, what I recommend is taking something like the speed questionnaire, which is public domain. You can print out some of those and have patients for 2 weeks just fill out the speed questionnaire.
Yeah.
Take that into the exam room, and I would say on the back of that sheet, because you're going to have some patient identification on that as well, on the back of that sheet you want to press on the Meibomian gland. So number one, see if they have symptoms. Number two, press on the Meibomian gland, see what the meibum looks like, because now you've looked at the function and whether or not there's meibum. And I would suggest the other thing now, since we have treatment, is have the patient look down and see if there's Demodex. So 3 easy things you can do. Have them fill out
Step 1,
a questionnaire.
Fill out the sample. Step 2,
Press it.
cut a hole in the box.
Yep, press on it. And then after that 2 weeks, then you can just compile. You don't have to address any of these patients at that point. Just take a look and find out what your patient demographics, what that looks like, and what the potential is in the care that you're not giving to the patient now, and just get a good idea. Is it worth investing in equipment? Is it worth having the patient look down? Is it worth pressing on Meibomian glands? You will know at the end of that 2-week period.
It is worth having them look down.
It is.
Yes.
It is.
What are you doing now, Doug? Oh, you are doing what? Oh, a little.
Meibomian gland expression.
Yeah, look at that.
Same individual, huh? Mm-hmm. He's still not happy.
Nope. Yeah, he looks angry.
Kind of.
Yeah. What?
Rugged Nordic
is he?
type.
Yeah, is he European? He's got that whole European vibe.
Yeah.
That cranky European look. Mm-hmm. There it is. What do you got?
Yeah, starting to look at that.
But
thicken.
just you can see the thickening around the glands and also the telangiectasias. You got nothing coming out of there, my friend.
And then when we do get something coming out on one of them, what we're going to find is it's going to be real thick. And that's a concern. I mean, you're not getting good oil out. You're just not getting any out.
So how much pressure do you think you need?
Since the amount that should come out with a blink is just that pressure of the blink, you shouldn't need much. And when you have to press a lot to actually get that out, then you realize that there's obstruction.
Right. I think it's interesting because what you just described is, if you're pushing to the point where a patient goes, oh, I can feel it, then, there's a challenge there.
But you look at the lid telangiectasias, the thickening on it, and then you can see the inspensation.
Totally.
And see that, and really, there's a belief also that this inspensation is certainly from lipases and enzymes released from biofilm, which a biofilm is a surface, a bacteria, and moisture. Those 3 components make a biofilm, and that those exotoxins then get in and go through this esterification, which could then cause that obstruction. So
what is the future of meibography?
Well, I think the whole deep learning and machine type learning is going to be going where it can look at that and give you the grading. It can tell you an awful lot, but I still think that we're going to have to press. We're going to have to get that.
So this was presented at the AAO 2023. This is our academy here. And they found that the algorithm produced standardized real-time inference and more objective clinical assessment loss to aid in clinical staging. So to Doug's point, it's that old, kind of like in baseball, right? It's like you have the whole, what is it, the money ball, right? Where
Right.
you can look at the metrics, or you can basically just get your gut feeling, or it's a little bit of both. And I think that's exactly what's going to happen with the future of meibography. We're going to have the AI.
little bit of both.
A little bit of both.
Yeah, a little bit of both. That's
tactile, a little good stuff there.